and we welcome you to our this course on submacular and subretinal hemorrhages. All the recent updates in the management of these challenging situations, and thank you for joining this course. And with me, I have a very good team of co-instructors. Dr. Avnish Upadhyay, he's a senior vitreoretinal surgeon working at IQ Hospitals, Gurgaon. Then we have Dr. Raju Sampagi, again a very popular, innovative, and a senior retinal surgeon working at Bangalore. We also have Dr. Raja Rami Reddy. He is again a very experienced vitreoretinal surgeon and practicing at Hyderabad, owner of Neoretina Institute. And I invite all my co-instructors to be with me at DICE. And I think idea behind this instruction course was to share our last 2 decades of experience of managing these submacular and subretinal hemorrhages. And you all know this can be a they can come in all shapes and sizes. It can be a small localized hillock kind of submacular hemorrhage to a huge mound of subretinal hemorrhage which is spanning across the arcades and going till equator. So, and we also have our 4th co-instructor, Dr. Shubhendu Boral, who is a local guy, and he is busy with some session. He will be joining us very soon. He is again a very senior vitreoretinal surgeon practicing at Disha Eye Hospitals. So, without further ado, I'll invite our first speaker, Dr. Avnish Upadhyay, to start with his presentation. Dr. Avnish will be presenting on initial assessment and how do we decide our approach based on that assessment. So over to you, Dr. Avnish.
Thank you, sir. And at the onset, thank you for having me for this session. So I'll be talking very brief about how to go about with the initial assessment and evidence-based approach as to what we have now and how to go about before actually treating these sort of patients. So basically, when you have a patient with submacular hemorrhage, what is the pathophysiology? We actually tend to see that there is presence broadly of blood between the RP and the neurosensory retina. Broadly, the causes could be choroidal or the retinal vascular abnormalities. Why it is important to know why these submacular hemorrhages are having issues is they do tend to cause photoreceptor damages as early as 2 days, and that can be reversible after almost 2 weeks. So what actually happens is when you have these sort of heme developing and there is this iron toxicity to the photoreceptors, and the fibrin meshes form that contracts, and that kind of hinders the nutrient supply to the retina, to the blood-brain barriers which are present, and that leads to eventual macular scarring. At the cellular mechanism for the submacular hemorrhage, we tend to see oxidative stress and inflammation because of these pathologies. So the most common causes I would want to illustrate are age-related macular degeneration. We have PCVs, pathological myopia, retinal artery macroaneurysms. The others which we uncommonly see are traumatic patients with choroidal ruptures. One of the other causes which we see more commonly is Valsalva's maneuver or patients with Tertian syndrome. So one thing which we need to understand here is what is the location of the submacular or subretinal heme. And the classification as it goes, it could be sub-RP between the photoreceptors and the RP, and under the ILM or between the ILM and the vitreous. Why it is important to know this is because the prognosis is how the placement of the blood is. So if you have on the inner surfaces of the inner retinal layers or maybe in the vitreous cavity, the prognosis is very good, and they do tend to sometimes resolve spontaneously. But if it is sub-RPE or between the photoreceptor and the RP, the prognosis is generally poor. So we need to investigate these sort of patients, and one of the most common modality which we have is to do OCTs. So in the previous slide, as I can show you, this patient came with a subhyaloid hemorrhage, and you tend to see that you can do an OCT and we can understand where the blood is. So we can see that this is the amount of blood which is there under the ILM, and this is the area where the blood is sub-RP, and there could be some vitreous hemorrhage which can make out it is pre-retinal or maybe in the subhyaloid space as well. So these patients, if you do a hyalodotomy, your management kind of actually is also focused on what we tend to see. So if the fovea is not involved and you see subhyaloid, because sometimes we generally tend to take these patients for hyalodotomy, and if we have not done an OCT, we may not be able to pick it up, and our management would be different. So the other investigation which we do also is FFA and ICG. That is important because along with treating the submacular hemorrhage, we should know what is the underlying cause, because unless we don't do that, the proper treatment or the total treatment will not happen, and we can have a very good approach. If a patient is coming with PCVs, giving intravitreal aflibercept would be of prime importance. The other thing which I want to emphasize is why we need to do an early and prompt treatment for these patients. So this was a study which was done way back in 2004, where they used to do surgeries for subhemorrhagic choroidal neovascular lesions. And they had this report where they actually they had around 334 patients, of which 168 patients were in the control arm. And the criteria here was these patients who had a subfoveal neovascular lesion, which was of the size 3.5 disc areas and composed of at least 50% of blood, and the visual acuity was less than 220 to 200. So after 3 years in these sort of patients, they followed up. So 87 patients were followed up at 3 years, and those patients, only 8% of them had a better visual acuity of 20 to 200. And you can see that with these sort of patients, the visual acuity does tend to go down if no treatment is given. So if you are not treating these patients, almost like 2/3 of the patients will have decreased vision. So we need to treat these sort of patients. So now coming to a patient which we have, and we decide whether this patient will have good or poor prognosis. This is one of the articles which was published, and this is from the people from Thailand. So from their study, they came out that PCV was most commonly diagnosed cause for submacular hemorrhage. But then again, they did come out with the patients who had poor visual acuity at initial presentation, and if they had neovascular AMD, an elderly patient, and if they had persistent of submacular hemorrhage, those were the patients who had poorer outcomes. This was again a study which was done way back in 1990, and they said that they had similar outcomes, but they also discussed about the thickness of submacular hemorrhage. So if you have a submacular hemorrhage which is more, the thickness is more, that has poorer prognosis. And they had said that if the diameter of the submacular, if you see a massive submacular hemorrhage, the extent is not a predictive factor for your prognosis. So even if you have a patient who has a flat lying submacular hemorrhage, that may have a better visual outcome as compared to someone which is more localized but with more submacular. The height is more, that could have a poorer visual prognosis. So this is one of the classification I came across where they talk about this is something called as flat caps. And they are talking about the different prognosis which we have discussed. So they say whether the fovea is involved or not, which type of layer, retinal layer is involved, and the age of the presence of macular hemorrhage, and the size of it, and then the the thickness of it. So broadly, even they are talking about if they have these sort of if the duration is more, if the height is more, or the extent is more, those are the ones where we need to hurry in doing the treatment, and we can actually prognosticate the amount of for these sort of patients. I would like to hear it from my co-authors as to how to go about with this, whether they use these sort of classifications for that. So to conclude, the treatment options for this is, which we have it, is pneumatic displacement with or without anti-VEGFs. The other options is vitrectomy with or without subretinal TPAs, and some have even tried photodynamic therapy. This was an article which was recently published in 2024, and they said that there is no gold standard treatment to it. So to conclude, submacular hemorrhage, if you have, it's a serious threat to your visual acuity. We should know what are the poor prognosis patients, and for each sort of patient, the treatment is more tailored, and it depends on the characteristic of the hemorrhage and patient's overall health and the visual acuity goals which we have. Thank you.
Thank you, Dr. Avnish. I think we'll be having discussion towards the end of all talks, or if anyone has, they can. Right now. Yeah, we can keep all the questions towards the end of the course because probably the next speaker may be addressing few of your queries. So now I request Dr. Deependra Vikram Singh as a Medical Director, Retina Services for IQ Hospitals to give his talk on displacement with gas alone without going for the fancy TPA and anti-VEGF. Is it underrated? How to get a large bubble and success rate? Thank you, Dr. Deependra.
It's on there. Yeah, thank you, Dr. Reddy. And I think Dr. Avnish has done a wonderful job setting the context that why we need to get rid of this blood and what are different modalities. And you all must have seen when these cases they present to our clinics, it's most of the times a very acute presentation. And some of them are already a known patients who are taking anti-VEGF injections and they give you a call that I'm not able to see anything. And first thing that comes to your mind is that poor guy must have developed either some macular hemorrhage or RP rip, right? So it is a little an acute emergency kind of situations for us. So and how do we treat it? I think again very nicely listed by Dr. Avnish that we have two options only. Either we can displace it or we can remove it. So and prognosis, if you ask me, the most important factor which would determine the prognosis is the height of heme at the fovea itself. And of course, chronicity and underlying pathology which has led to this bleeding is also going to influence the prognosis. So pneumatic displacement is not new, and we use gas for so many different reasons. So everybody is familiar with now gas and its properties. And I'll just straight away walk through few cases and then try to make a point, which is the title of my talk. So this was again a post-traumatic submacular hemorrhage in a young patient, and those days we were not doing that many OCTs for these cases, and our understanding of OCT for submacular hemorrhage was limited. But we were doing FFAs to rule out any other reason. And this patient, we injected gas and with followed by prone positioning. You can see the shadow here. And over the next 6 to 8 weeks, blood resolved nicely. And you may argue that it may not have displaced, it might have just absorbed. So, but just have a look at this white field montage, and you can see that all the blood has shifted downwards because of that prone positioning. And if we would not have displaced this blood, you would have ended up this kind of accumulation and scar and organized clot at the macula itself. So point what Dr. Avnish was telling, that this looks like a small extent of hemorrhage, but there was a lot of blood lying at macula. I didn't have the OCT at that time for this patient, so we couldn't measure the height, but you can see that displacement made a huge difference to this patient. But I think eye-opener for me, especially in those days of practice, was this patient. She was a 65-year female, and she had a history of sudden loss of vision for last 1 month. And you see the extent of submacular hemorrhage. In all the studies where they evaluate the interventions, they label it as big, large, massive hemorrhage when it is spanning across the arcades. So, and this was a lady who would not be eligible for any kind of surgery, or she would not be able to afford TPA even. So I said, let me try gas as a trial. I'll give you gas same day, today itself, and ask you to do prone positioning. And she was quite obese. So we did that, and you see this, what happened after just 2 days of gas injection. And what you can notice is we got a really large gas bubble in this case, which is coming down. The meniscus is below the arcade. And that is how you can judge the size of your gas bubble. So because of that large gas bubble and immediate prone positioning, she got significant displacement. And we could do it same day, and rather her pressure became very high. I had to do paracentesis 2 times to get that large bubble. And end result was quite satisfactory. She came to us with 3/60 and almost a lost eye, and with followed up with anti-VEGF injections, she could regain 6/36. So something I learned from that case is it is never too late. If you get a red-looking, dark-looking submacular hemorrhage, give it a try. It might still displace, and you can change the final outcome. So the point what I am trying to make is why gas alone? There are now treatment options available, TPA, that you can go subretinal, you can do more extensive surgery. But for me, gas injection is like a first aid. Whenever patient lands into our retina clinic, the gas is always available with us. You can offer it then and there only. And that is what I tell all my anterior colleagues also, send patient prepared with for gas injection at least. And so TPA and all other anti-VEGFs, you will have to get approvals, arrange for it, patient has to be ready for that. And interestingly, it will do job for most small and moderate size hemorrhages and significant number of large submacular hemorrhages also. And I am not a big fan of intravitreal TPA these days. For me, because of the cost involved, I would prefer to inject it subretinal rather than giving just intravitreal. And it has not been proven to be better than subretinal TPA in any of the comparative studies. And if you eliminate the impact of gas and pneumatic displacement, it's very difficult to judge the impact of intravitreal TPA. I'm not talking about subretinal TPA. And the fourth argument in favor of gas alone is you can always go for a stepwise approach. Inject gas, make prone positioning, ask patient to come back after 3-4 days. And if you have some failures, patient gas is not, blood is not getting displaced, you can then proceed for vitrectomy. And another thing which I am quite against is going for a cocktail kind of treatment, giving intravitreal anti-VEGF also immediately, because they are less likely to penetrate thick clots lying over the CNVM or polyps. So it makes sense to inject gas, displace the blood, and then you give anti-VEGF after 3 days or 5 days. And of course, shifting is not a one-time affair. We have seen it. You shift it with gas and you feel that shifting is still not adequate. You can go ahead with vitrectomy and shift it further. So it's not that once blood has shifted, it gets organized immediately. So stepwise approach, you have nothing to lose. That is the point I wanted to make, and I'll show a few more cases in support of that. So again, this was a very old case. I was managing his right eye. In fact, his son was a very senior scientist with Genentech, and that's the reason he was sticking to Avastin only. And the meanwhile, his left eye, he presented with a CNVM and hemorrhage, which we have never treated. So these fellow eyes definitely are at higher risk, and we injected gas and it shifted temporally. And you can see, and then we treated him with Avastin, the left eye also. He had second episode, second time also gas injected, no TPA, again it shifted nicely. And then he had a third massive episode. At this point of time, I asked him for surgery, and somehow then I think he was lost to follow up. So, but the point is that even recurrent bleeds, they also shifts nicely with just gas without any TPA. Now, another, I think this case I wanted to share exactly to highlight the same point what Dr. Avnish was pointing out, that sometimes you feel that it's a very small amount of hemorrhage lying at macula. And this is the one-eyed gentleman who has lost other eye to advanced AMD. But if you see, when we do scan, you can see a very tall accumulation, a significant height of subfoveal heme. And that was correlating with his visual acuity, 5/60. So again, this is the case. We will go ahead with just gas alone, no TPA. And this is a picture at 3 days, and you can see at 1 week, significant reduction in the subfoveal heme. And blood has shifted temporally and inferiorly. This is again one point I wanted to highlight. When you are planning to displace blood, always realize that this blood is going to shift down and temporally. So the amount of blood which is lying above fovea and nasal to fovea, the extent of that blood also you should take into consideration when you are planning your approach. So I think this was again a patient with polyp. She came with subretinal fluid and PED, and we were planning ICG, but she had another episode of bleeding, and blood was now subfoveal. And you can see the difference. When blood was not in the subfoveal area, the visual acuity was 6/18, but it dropped to 5/60, and now she has blood. So our plan changed now. Of course, polyp was there, but we injected gas, and it shifted nicely. Another patient with large amount of blood superior to fovea. Now, for me, this is a massive hemorrhage because I have to displace all this blood away, down and temporal. So I will go for a larger bubble. Again, you see the meniscus of the gas bubble, it's reaching right up to the arcade. Another patient having a significant blood in the seeing area, despite the patient having this scar, again shifted. So the next question is, how do we achieve bigger bubble and get significant displacement with just gas alone? One, I think, modification which I have been doing for almost 10 years is I do not inject pure gas. What I do is I take 0.2 ml of C3F8 and then I make it 0.6 ml by adding air through the filter, so that now I have 0.6 ml of minimally expansile gas in 1 ml syringe, and I try to get a very big bubble on the table itself. And if IOP starts getting high, if once you cross 0.4, 0.5 ml, so I do paracentesis and check for light perception. If light perception is not brisk, and you can check it with microscope, if light perception is not brisk, I normally would go for second round of paracentesis. So I'll just show this video. I think I'll wind up just last case. Again, a young lady with PCV and subfoveal hemorrhage. And you see the extent is not big, but you see the height. Sub-RPE and subretinal blood is huge. So this is the technique. Incidentally, we have recorded this, but normally we would not record intravitreal gas injection, but this was recorded, I think, last year, just to show that how you inject gas in these cases. All my VR colleagues, they know it. You have to stay in the bubble, withdraw the needle, and this was a fairly large amount of gas bubble we could achieve. Minimally expansile C3F8, and here I am using microscope light to check the light perception. I realized that even after paracentesis, it's not going down. So I will do this very rarely, but here I reduce the size of gas bubble just to ensure that light perception comes back. And you can see, even with that size of bubble, a significant displacement happening in this case, and a significant amount of blood getting away from fovea. You can see the height going down. And because I have reduced the size of bubble, the meniscus is upper. And in long run, she did well. So to conclude, I'll say yes, pneumatic displacement alone as an intervention has been underrated, and it's a viable alternative. Especially, it's a low cost and immediately available. So that is the huge advantage. And it doesn't interfere with additional interventions. If you need to do vitrectomy or anything subsequently, it doesn't interfere with that. So thank you.
Thank you, Dr. Debendra. We'll take last. You can take questions. Yeah. I was just one question I think we'll ask is that now in your experience with this gas injection, how most of the displacement occurs in the first 24 hours? Is it, or how much you inject gas and maintain prone position?
Yeah, so I think that's a good question, and in fact that explains why I use C3F8 in first instance, because I could have used SF6 also. This keeps on happening. So what my end point is, when my fovea is almost devoid of blood, at that point I stop prone positioning. And somehow, in the interest of time, I have not shown the serial pictures of some later patients. Shifting is not one-time affair. You continue prone positioning, it shifts further. And that is the beauty of this pneumatic displacement. So it's not that it will shift everything at one go. So that's why I go for prolonged prone positioning in patients having larger hemorrhages. And my surgery time, if I have to go for surgery, would be at least week or maybe 10 days after I have tried enough prone positioning. So I don't jump for surgery immediately in these cases.
Yeah, that's a good point. What my understanding has also been, even though the most of the displacement maximum happens in the first day, but some more happens over the next 2-3 days, and it's good to maintain try to get a larger bubble. And just in case you don't even have gas, I think it's fair enough to give a plain 1 cc air to the patient in your clinic after giving mannitol and one prone position, and even still you may see some amount of blood getting displaced. Yeah.
But bleed happened after almost 5 months. He had multiple anti-VEGFs in between. I think risk of immediate rebleed is substantially low. But yes, in long-term follow-ups, they will bleed again, because polyps especially are notorious to have recurrences. And there are two things which goes against giving anti-VEGF with the gas. One is you compromise the vitreous volume. the amount of gas you want a big, large gas bubble. If you inject anti-VEGF also, then you will not be able to achieve that large bubble you want to achieve. Second, most of the times, these patients, if they are already on anti-VEGF, they are anyway due for their anti-VEGF either 2 weeks later or 3 weeks. So I don't want to break that thing. For me, it's a accident, RP, RIP, or submacular hemorrhage in a patient who is known to have CNVM. So I will let him follow his original schedule, whether it is PRN or something. Bleed is not an indication for additional anti-VEGF. Third, there is cost involved, approvals involved. Most of them, they land into our clinic as an emergency. So gas, we do it at very subsidized charges. But for anti-VEGF, we have to plan for, we have to send the approvals and all.
So basically, pneumatic displacement is kind of the thing you are saying is kind of emergency management.
Yes, and it's worth it. In our clinic, I have hardly remember any patient whom I have sent back without injecting gas. I just tell them, wait, I finish my OPD, put gas, and you go after 3 hours. This is something which needs immediate addressal, and that way we can reduce the duration of hemorrhage.
Yeah, excellent, Dr.
Thank you, sir.
Dr. Dipendra. We'll take. Yeah. Okay.
I would want to know, sir, when you are like, do you keep the eye hypotenuse after putting the injection, or you keep it very tight and just because is there any difference to it? Because unlike retinal detachments, this is something like we are increasing the pressure onto the eye. So how do you titrate your pressure once you inject?
I think for me, treatment endpoint, IOP endpoint is one is I check it by palpation, and second is this light perception. The light perception has to be brisk, and you can actually ask patients to count fingers also. So as long as, and of course, then you will anyway see the patient before he or she is leaving the hospital. If pressure is still high, you can address it. But for me, keeping eye hypotenuse doesn't give any advantage, and high pressure also is not going to displace blood more than normal IOP, because in a non-vitrectomized eye, it doesn't influence the displacement. The only worry is you should not get an artery occlusion or that thing.
So one last question, sir. In a treatment naive patient, how many days after pneumatic retinopexy you would, after injecting gas, you would give anti-VEGF?
That's a good question. So what we do is we call them after 3 days and then after 1 week. And if my fovea is absolutely devoid of blood, I give it on that second visit itself. And interestingly, one of that one-eyed patient, he was too much troubled by C3F8. So at 2 weeks, when I was planning his anti-VEGF and I saw that blood has significantly displaced, I just removed the gas also, because he was too much troubled by gas. He was one-eyed, and gas interferes with their walking and climbing stairs. So that is again one advantage if you are not clubbing anti-VEGF with gas. If your gas does job within a week, take out gas, put anti-VEGF in that sitting.
Yeah, okay. We'll take more questions
Actually,
towards the end of the.
Actually, we just whenever hemorrhage is there, so that polyp or the new vessel has ruptured already.
Yeah.
So it blocks that thing already.
Yeah.
So
There is no urgency.
There is no urgency at all.
Yeah. So you treat it on merit, not that accident has happened.
Next speaker is Dr. Raju Sampangi. He is a senior veterinary surgeon practicing at Netra Spandana, Nagar Bhavi, Bangalore. He'll be talking about the role of RTPA, recombinant TPA. Is it a first line or reserved as a second line? Where does it work best? Dr. Raju, please.
Thank you, sir. Thank you, Dr. Dipendra, for including me in this IC. And let me see whether I can convince you to use a TPA from your pneumatic retinopexy. So this is the brief overview of what I'll be speaking, basically a rationale for the use, the history in the background, and what works, whether it's intravitreal or subretinal, whether we should use it with gas or without gas, and the timing, and some practical aspects about the preparation of the drug itself. As far as indications for TPA is concerned, acute thick submacular hemorrhage in the subfoveal region, recent onset, would be an indication for use. And why you require treatment early is we know that there is clot contraction, there is toxic effect of iron, and a diffusion barrier that leads to photoreceptor damage, and it happens as early as 1 day. So going back to our MBBS days, this is how the clotting mechanism would work. The thrombin would work on fibrinogen to convert into fibrin, and this would be a part of the clot. So what we are interested is in this part, the tissue plasminogen activator. So whenever there is an injury, the platelets are recruited and they get activated and then they start collecting. And the thrombin acts there and it binds these platelets into a with a meshwork leading to a fibrin mesh. So this is how the clot looks like, and the TPA would act on the plasminogen which is bound to the fibrin and convert it into the plasmin, and after that these strands which are holding them are broken down. So this is how it works like. As far as role of TPA in subretinal blood is concerned, there are many animal studies which establish the role for subretinal TPA. So how does it, which works? Is the intravitreal better or subretinal better? Actually, the reports are very confusing and very contradicting. This report showed that intravitreal TPA doesn't diffuse through the intact neural retina and reach the subretinal clot at all. While this study published in Retina revealed that intravitreal TPA actually is present in the subretinal space after you inject, and it results in rapid clot lysis in rabbit eyes. And another study shows that intravitreal taking place in pigs was able to penetrate when given intravitreally. This is another study published recently around 2017 in rat model, wherein they use altiplase in unconjugated TPA, and again it was injected into the vitreous and it was capable of penetrating deep into the retinal layers. As far as the clinical studies are concerned for intravitreal TPA, Heriot was the first one to report its use in a clinical meeting, while Payman used subretinal TPA in a surgery in 1991 itself. So it's almost 2.5 decades. If you look at the various studies which are there, there are many studies wherein the intravitreal TPA has been used. Here they compared the subretinal and intravitreal TPA, and they conclude that both treatment modalities effectively displace the submacular hemorrhage in this exploratory trial. This is another study published in Eye, wherein they said that the intravitreal TPA was valuable for submacular hemorrhage only in eyes with relatively old hemorrhages, and for eyes with recent onset hemorrhage, TPA is suggested only if the initial gas injection failed to displace. That's what they concluded. This is another study wherein they compared subretinal versus intravitreal. Again, according to their conclusion, both treatments proved equally efficacious. This is one more study published in Retina, wherein they had 39 eyes and they did into 3 groups. One was a vitrectomy with subretinal TPA. Second was intravitreal TPA with pneumatic displacement, and third was only pneumatic displacement. What they found was in both the intravitreal and the subretinal TPA group, that's the TPA group, they had good improvement in vision, while the patients with only pneumatic did not improve. But the number of patients were less, I would say, around only 9 patients in the pneumatic displacement group. But they said that the pneumatic only displacement did not work well according to this report. But does only TPA, intravitreal TPA work? It doesn't work. So if at all you have to do it, you have to do it along with a pneumatic retinopexy. Now again, that begs back to the question that what is working? So I would still say, I would go with Dr. Dipender and say that if at all I have to give an intravitreal TPA, I would combine it with a pneumatic displacement. So this is one case that has been published wherein it shows that intravitreal TPA plus gas does work, and this is when you give subretinal, definitely it is a yes, but it comes with its own set of risks. Now if you compare these 2 images published in the same publication, you can make out that the intravitreal TPA has almost worked as good as the subretinal TPA if you look at, compare the images and the way it has responded to the treatment. So intravitreal TPA has its advantages in being a simpler with lesser risk of complications and being more accessible because you don't have to perform a surgery. While it may have limited direct exposure to the clot itself. While subretinal TPA is the place where you should give the injection, that is where the clot is, so it will be more rapid and effective in clot dissolution comparing to the intravitreal TPA. However, it's an invasive procedure, requires a surgical expertise and higher risk of intraoperative complications. Now, in which patients to consider subretinal TPA? The thickness of the hemorrhage is one thing that I think is very important. In thick hemorrhages, especially if it is more than 250 to 300 is what many studies take, and some of them say it is 450 microns. But if you feel it's a very thick hemorrhage and the vision is less, then one should consider subretinal TPA in these patients. And when it acts best, as soon as possible is the answer for that. Of course, there are other factors, patient factors that we need to consider before we take these patients for surgery. As far as complications of use of TPA is concerned, the patients can end up with a vitreous hemorrhage, a rebleed, high IOP, retinal detachment and macular hole whenever we are injecting in the subretinal space. Again, the toxicity can also be dose dependent, and any dose which is more than 50 micrograms is said to be toxic. So a dosage of 25 microgram is recommended for use. Now coming back to some of the drug practical aspects, which drug, dosage and preparation. So as far as the streptokinase is concerned, it binds to both bound and unbound plasminogen. So and high antigenicity, it is not usually used. And while the alteplase, retiplase, and technetoplase acts on the bound plasminogen. However, alteplase is the most commonly used one. And compared to both of them, the other one, TNK, is supposed to be more efficacious in clot thrombus dissolution, at least. Now, how to prepare? This one, the Actylase comes in 10 mg. So it comes in 2 bottles, a dry and a bottle with a saline, and you have a connected to it. So you open both the bottles and connect the saline into the dry powder, and the fluid goes into it, and then you just shake it. At 10 mg is there in 10 ml now. That gives us 1 mg in 1 ml, and take 1 ml of this and make it up to 10 ml using sodium chloride, and gives us a concentration of 100 microgram in 1 ml. And we can inject up to 0.25 ml of this drug, of this 100 gram in 1 ml solution. These are the various cannulas that are used to inject, and some of the specialized injection kits are also available for this. Now, as far as TPA being used in submacular hemorrhage, you also have the choice of using an anti-VEGF. Now, there is one report which says that when you combine it with aflibercept, it actually cleaves that, and because of that, the effect of aflibercept is less. So this is one thing that we have to keep in mind when we are combining it with TPA. So the management of submacular hemorrhage presents a complex and challenging scenario. There are various things that we need to consider, but one thing we can probably consider is adding it intravitreal, which is the most easiest thing to do. So in real world, what happens is basically when the patient is there, the ideal situation is to give it subretinal TPA doing a surgery, while practically what many of us can do is to give the intravitreal gas as a first aid, as Dr. Dipender sir said. If you see this patient had a blood pressure of 200 by 140 3 days before, and he came with a submacular hemorrhage, probably a ruptured ram. We gave him a pneumatic displacement. You can see very beautifully this blood got displaced, and the vision improved from hand movements to 6 by 36 at 1 week. Now, one more important thing is in patients with RAM, they have a risk for rebleed. And all eyes in this study, in this published study, all eyes who had a macronism had a rebleed. So the clot was actually plugging it, and you lyse it, so it may lead to a rebleed. So this thing also we need to keep in mind, and in these patients maybe a pneumatic displacement would be a better choice. To answer all our questions, RCT is under progress, the Tiger study, and hopefully it will answer many of our questions. So ultimately it's imperative to weigh the potential benefits against the risks and limitations of each approach while considering patients' individual circumstances and preferences. Thank you so much.
Thank you, Dr. Raju, for doing excellent work and very nice presentation. You have done justice to the topic. And meanwhile, Dr. Reddy takes over. Just a small question for you. Do you try lasering your RAM after displacing the blood?
Not immediately. I have not
Okay.
tried to do it immediately.
Okay. But then when do you do it?
Usually once the whole area is cleared of that hemorrhage, probably I think of doing it at that time. The uptake sometimes may not be good because of the hemorrhage still being there. If it is completely displaced, probably it can take up better.
Any other question for? Yeah.
I have one question for you, sir. Do you counsel patients for having vitreous hemorrhage after you inject the gas? Because that
Absolutely,
can happen.
absolutely.
is
Both, if you even if like Dr. Amnish was showing YAG Hali.me, those patients 100% will have floaters and vitreous hemorrhage. Here, I think if you inject gas, 5% patients will have breakthrough hemorrhage, especially those having massive hemorrhage, and polyps and neovascular AMD patients are more likely to have breakthrough rather than post-traumatic and younger patients. But we have to inform them. We have to tell them that you might need a vitrectomy for one reason or the other. But as a first step, we are injecting gas, and if you are lucky, we'll get away with that.
Thank you, sir. For Dr. Raju, I have one more question. Is the dose same for intravitreal and subretinal TPA? Because in subretinal TPA, the TPA will act directly on the clot, whereas the intravitreal it has to go through the vitreous and through the clot. Is the dose the same, or is there a difference in you use a higher dose for?
The reports do not make any difference as far as the dosing is concerned.
So one
Most of them
standard
say,
dose for
one standard dose. And when you are giving subretinal, actually you are giving lesser injection because the space also is less.
less, yes.
That's the other thing that we keep in mind. So actually when you are giving 0.1, it will almost come to 10
Yeah.
to 12 only.
Have you repeated any of these injections? Because, and how do you see if you see a patient you have injected? So what are the parameters you would see? Whether you see only the foveal clearing there, and when do you think about that this patient may require a re-injection?
No, I basically look at the foveal clearing itself. So once the fovea is cleared and the vision has improved, I don't think of anything else, because that's
And I
what
think,
it matters. And if you wait, the patients will recover. And I also one more thing is, as far as displacement, when I'm using pneumatic retinopexy, not pneumatic displacement, I keep serial OCT and keep seeing how much is the subretinal, and till it completely gets flat, I ask them to do bone flush. That's what I do personally.
So one last question can I ask? Sorry. If you have a large hemorrhagic PED, where will you inject? Hemorrhagic PED, arcade to
Dr.
arcade.
Reddy is going to
Sure. Okay.
show the modified technique.
Yeah, and that hemorrhagic PED, we don't try to displace too much of a hemorrhagic PED. We are only concerned with subretinal hemorrhage that is more toxic. PED, whatever hemorrhage is behind the PED, we can leave it alone. That's not a big concern for us. Today I'll be talking about this, the next step that we've thought, that stepwise approach with gas or gas plus TPA. If it is huge or some indications, we have to think of subretinal TPA and with or without gas. That's the thing. So the main inventory when you plan to decide to do subretinal TPA, what are the things that you need apart from the drug is that subretinal cannula. This is one thing that you need to keep it handy, that whatever one odd case that you get once in a year, or there are expanding indications for subretinal cannula, 38 gauge or 40 gauge attached to 23 gauge or 25 gauge trocar, whichever is the favorite one that you're using. The other one is a microdose injector, but you can as well, when we are injecting a drug, most of the times we cannot find another patient who will require a TPA. So you mix the entire drug, you can attach to a 10 ml syringe the entire drug or whatever little, and use this cannula and use for that one patient, and use the Visco VFI injector from Constellation and then inject the drug. So 10 ml syringe. So basically you need the 38 or 40 gauge cannula from Med1 is what that we need to use. Now, when we decide to do, when you give an injection, what are the parameters that we need to keep for while giving? Ideally, you try to keep the IOP slightly low, or around 10 millimeters of mercury, so that if you keep the IOP high, then you find it difficult to inject the drug to the subretinal space. The other thing is how much is the injection pressure that you plan to do. This has not been studied in submacular hemorrhage injections, but various studies where subretinal gene therapy is being given, enough literature is there where they show that the roughly the 5 to 8 psi is what that pressure is required to inject drug subretinally, and also initially for the creation of the first bleb of drug that comes subretinally, you slightly require more pressure, whereas once the bleb is created, to propagate even slight lesser pressure. So 5 to 8 is for a bleb initiation, and then 4 to 7 will be for bleb propagation. So, and one more thing, because in this because we don't have access to intraoperative OCT, we all depend on our ability to see through and to exact the location of the tip of the cannula, whether it is exactly subretinal or it is pre-retinal. The only way you will know is sometimes you press and you see a reflex, that means you've not yet gone. The other indication is that if you see this kind of thing, it is obviously not gone into subretinal space. And if you see a displacement, you see a blanching around the tip, that is blood is displaced. It is still not at subretinal. It is there because it is pushing, then needle is pushing the blood away, that is why it's getting displaced. Once you actually enter into subretinal space, again it will come back to normal, like how it was before, like this. So when you see a blanching, that means it is still not in the subretinal space. You have to go slightly advance further. And this is one of the first case of subretinal hemorrhage which I have done, is a one-eyed patient, retinitis pigmentosa with a subretinal hemorrhage. The reason we do not know, I could not find the cause even after displacement of blood. Yeah, this is one of the first cases. I have done it injected manually to the 1 ml syringe, but now currently we do viscolar VFI module from Constellation and as described. And one of the concerns that we see is that we do not want to have a blowout macular hole. That is a concern for us. So try to create a bleb at the inferior edge of the subretinal hemorrhage, at the inferior arcade, and try to create this bleb that goes inferiorly from the inferior arcade, so that the fluid, the subretinal TPA fluid doesn't come up and try to cause a blowout fracture, blowout macular hole which is there above. So once we see a good fluid wave, and you think this is a small hemorrhage, so at one place it's enough. Suppose you find a big subretinal hemorrhage, you may need to create 2-3 kind of blebs at different locations, and the maximum that we've discussed, we can inject up to 0.4 ml of this drug. Okay, this is how it is in the first postoperative. The plain air has been injected, and most of the vitreoretinal surgeons, once we inject subretinal TPA, we also want to do some slight modifications to basically increase the chance of displacement or displace it even further. Which is the most easiest modification, or which doesn't cost much, is subretinal injection of air along with the TPA. So there is logic for that, and this has been done in this study where they studied whether along with the TPA, if the air is injected, what is how the experience of displacement of subretinal hemorrhage. They found that in this 24 eyes in this they studied, the displacement of subretinal hemorrhage is complete in 100% of cases. The only advantage which they propose is it gets displaced even beyond the arcades in 75% of this patient if subretinal air is also injected, and even more beyond equator up to 20%. But even we see that Dr. Dipender has shown that even with intravitreal gas alone, there are quite a few cases where it is displaced even beyond the arcades. And interestingly, in this particular study, they found that even sub-RP hemorrhage was displaced in 73.7% of the people. Only in 25% the subretinal hemorrhage, sub-RP hemorrhage could not be displaced. So this is an injection of subretinal air. Yeah, this is a case of post-traumatic hemorrhage, a 30-year-old male. and this is a second case that we've done. And then this and the studies of subretinal gene therapy injections also have shown that age is a factor. The younger the patient that is there, you will find that the amount of pressure that you need to do to inject the drug is slightly higher. So this particular patient is the first time I was trying with the viscous fluid injector and not hand, and a couple of places I had to change the location because I was not able to inject the drug, and it was some amount of reflex was happening. This amount of reflex of TPA is not a big concern, but there's a big concern if you are injecting subretinal gene therapy. We do not want this much reflex to happen, so because that will cause a lot of uveitis. So, and while injecting, you have to make sure that you don't do any lateral movement of the tip of the cannula, because that it may get enlarged. The microretinotomy that you're creating might get enlarged, and they can. The advantage which they say with the subretinal air is that it forms some sort of an airlock. At least you'll see that whatever TPA that is injected probably does not come out into the vitreous cavity. There's one advantage. And in this if you give a subretinal TPA for the next day, you can make the patient sit, and that because the buoyancy of the subretinal air itself, that will also help in pushing the hemorrhage down mechanically and probably displacing it further. So this is how this particular patient behaved after this displacement, but there is foveal thinning. And there's another interesting case of a young boy, a 16-year-old boy with some large subretinal hemorrhage and also some amount of localized retinal detachment. Apart from hemorrhage, there is fluid accumulation also, and there is a thick subretinal hemorrhage, and also there is an open, there's a macular hole that is there that is already developed. This particular patient, subretinal TPA was planned. Once you get into the subretinal space and you start injecting the TPA, you see this amount of bleeding is already coming from the macular hole into the vitreous cavity. That was expected in this particular case because we know there is a macular hole, and once amount of, nevertheless as per plan, we continued to inject a little bit more of drug, and then that was followed by a inverted ILM peeling, and then the surgery was closed. And of course he had a choroidal rupture. You can see the hemorrhage is displaced beyond arcades, and this is how the patient behaved post surgery. The other interesting case of a laser proliferative diabetic retinopathy has come with sudden decrease of vision. It is not pre-oil, suboil, it is a subretinal hemorrhage that has caused the sudden decrease in vision. She was taken off for surgery, and following removal of the membranes, which took about 20-25 minutes in this particular case, and then by the time you can see the subretinal hemorrhage that was placed to be injected. Somewhere all after this, the media became hazy, and there is a feathery PSC that is developed in this particular case, and the media, and it was not possible to see the retina in this particular case, and we were at crossroads what to be done with this patient. So I injected silicone oil in this patient, and post injection of the silicone oil, through the oil again, with the clarity was slightly better, and then the injection was done to achieve a bleb, a small dose, and the patient is done well post this. Yeah, this is the same patient. So the other minor modifications which I'll be speaking about, it will take less than a minute. The theory is that if you remove the internal limiting membrane, the site where you want to inject. So this study has shown that if you remove a local ILM membrane and inject without actually penetrating the full thickness retina, the jet of the fluid injection itself can cause the drug to go inside the vitreous cavity. And probably this is worth trying. Probably the next case you can see, you can do local ILM peeling and place the needle tip on the retina and inject. The jet stream itself can cause enough microretinotomy so that drug gets delivered and the bleb is created. The other change is nanovitretinal subretinal gateway device, which is nothing but a handle with extendable needle, 30 gauge needle it is attached, and the trocar, the 40 gauge cannula tip is extendable from the handle, and this is a non-vitrectomizing way of injecting subretinal TPA. You can use a chandelier. This particular study is so you can use a chandelier, and with this 30 gauge needle, directly go and inject the drug into the submacular space without doing a vitrectomy. So that subsequently, when you want to give an anti-VEGF, you have enough vitreous and the half-life is of the anti-VEGF is not disturbed. This is an interesting thing to do it, provided we have this device here. The other way is, if you're a beginner and you're not sure whether you want to visualize the bleb, whether it's actually going inside or no, you can do a you can stain the drug TPA with a fluorescein strip, and then injecting. While injecting, you can have a look the bleb that is being created, and be happy that it has reached the correct destination where it is intended to be. Improved visualization and also ability to review the influx. Thank you.
Thank you, Raja sir, for the wonderful presentation. And now invite Dr. Dipender sir to present his next talk on minimalistic approach and draining only what matters.
Right. So, can I have the slides, please? Yes. So, after seeing those subretinal TPA, now next step is if you encounter the bigger problems. So, I think this was one case I wanted to share with everyone. This was in fact our first case when we restarted surgery after COVID lockdown. So she was a lady who had cataract and posted for cataract, and when cataract team realized that there is no glow, there is dense vitreous hemorrhage and probably retinal detachment or massive subretinal hemorrhage. So we took her for combined surgery, removed the cataract, and after removing this dense organized vitreous hemorrhage, and here you can see, despite the fact that she was having massive subretinal hemorrhage, her macula was spared. And at this point I was thinking, I'm not going to do anything for this blood, I'll just do fluid air exchange and leave it. But when I was doing fluid air exchange, this whole thing ballooned like anything, and it was threatening to involve macula. So I tried draining it transclerally, but it didn't drain. Just like I thought, just like we drain suprachoroidal hemorrhage, will drain subretinal bleed. It didn't. So I decided to leave it alone, and just with gas, and she recovered very well, 612 vision, and then we were planning to do an angiography to find out the reason for the bleed, but she returns with drop in vision, and she already had a history of macular hole surgery being done in her fellow eye. So she came with a macular hole in this eye also, and again the hemorrhage has already started organizing, and we planned a resurgery for her, and again the conventional peeling, and then we have used ILM flap. And even at that point there was significant amount of blood lying all around arcades and in periphery, and again it was tempting that should we do something for blood, but I again decided to leave it alone. And this is post-operative picture. The hole closed very well with the flap. This time she regained only 6/18. But this is very interesting. When you do angiography or autofluorescence, you can actually assess the damage done by subretinal blood, and that is a good way of assessing long-term outcomes in these cases. So you can see, despite having massive subretinal hemorrhage, but macula was not affected, she could maintain good visual acuity, and nothing was required to be done. So that's why I thought I should share this. And we were suspecting malignancy also. We did angiographies, PET scanning, but it turned out to be some inflammatory or hemangioma-like lesion, which we lasered nasally, and she settled down nicely. So this was one case, and then this another case, again patient with proliferative diabetic retinopathy, where we have done VR, removed silicone oil. He was doing well with 612, 6/9 vision, despite having very pale disc. And then this guy deteriorated. He was on dialysis, and he developed this sudden loss of vision and this submacular hemorrhage. And now I knew that this guy was on wheelchair, and he is not going to maintain any kind of position. Prone positioning was almost impossible. So again, we just decided we'll inject subretinal TPA and maybe some air and leave him alone. Let's see what happens. And again, the point what Dr. Reddy was highlighting, that if you are not able to get in don't try that point again and again, because you will end up creating a larger retinotomy. So go to another area, and this blanching happening tells you that you are still not in subretinal space. Yes, and then once you are in the subretinal space, you can see I have injected TPA followed by air, and again this fundus picture 4 weeks after surgery, significant displacement of blood, and we have just injected air in this patient. So again, doing very well with this minimalistic approach. Another patient, he was 90-year-old having dementia and I think COP, and he had a massive subretinal hemorrhage, almost hemorrhagic RD on ultrasound, and picture was like this. There was almost total detachment. I was trying to induce PVD, and at this point he got very restless and uncooperative. So again, whatever we have, I was planning the extensive surgery like Dr. Shubhendu is doing it very regularly. So, but in this case, because he was so restless and non-cooperative, I realized that I should not be doing extensive. I'll just do whatever minimum can be done. Created retinotomies in 4 different quadrants and injected PFO, and you can see everything is so shaky because my assistant, one of the assistant was holding his head, 2 guys were holding his legs, and somehow we could drain maximum blood with just these 4 retinotomies, and you will see in the end there was only inferior few mounds left. Remaining blood was nicely drained, and this was, and we injected silicone oil for obvious reasons, and this was his outcome at 6 weeks. He could regain 6/12 vision. Another patient having this submacular hemorrhage and some breakthrough hemorrhage also. We again, as a rule, tried intravitreal gas, but it didn't work much. So, and this is the point I was highlighting in the first talk, that if you have to plan a subsequent intervention, your first aid intravitreal gas doesn't interfere with that. Now, this is again, you see, patient has hemorrhagic PED here, and I'm going just at the edge of PED, and my interest is to displace this central blood, and you can see the bleb. And now I'm going to make another bleb in this area where I could see organized blood. And that's it. And here I was not keen to inject subretinal air because I was not sure whether it will be retained, and the retina was so thinned out, so I was not very keen to create bigger retinotomies. And again, this patient does very well. 2 weeks after surgery and 6 weeks, he regained his pre-hemorrhage vision of 6/60, and this was again a one-eyed patient, so I think it was quite reassuring for him. So to conclude, I think in general, when we are managing these even larger, bigger subretinal hemorrhages, our main target is to get rid of blood from macula and the most healthy retina with whatever patient is having at that point of time. And of course, like I highlighted, blood is going to shift temporally and inferiorly, so one has to plan accordingly. And again, I've already said this, that heme, just underlying fovea and the height of blood at fovea will help us decide our ultimate approach for these cases. Right. Thank you.
Excellent presentation. Basically, in your picture, what you have shown that effect of subretinal blood, that in I think FAF picture, the black colored area or RP rip area, ripped, because submacular hemorrhage never persists. It is neither always lies in combination, either sub RP or sub neurosens retina. They never like sub neurosens retina, not sub RP. Not sub only in sub RP space, not in the sub neurosens retina. It will lie in both combination. There will be some amount of rupture of the RP. So second thing is, purpose of giving this subretinal air is, just after giving subretinal TPA, the blood will gravitate. So RBC will gravitate, and because of the buoyancy factor, and will keep the lysed blood down. So it will make the clarity and improvement faster.
Excellent points, Dr. Shubhendu. And I think autofluorescence is a good way to see, assess our interventions, the efficacy of our interventions, because ultimately, right now we have been focused only on fovea and macula, but like what Dr. Reddy pointed out, one of the big advantage of doing subretinal air would be displacing blood, maximum blood to the equator. So I think in those cases we need to see what was the impact of short-term blood on the macular area and equatorial area around the arcade, and if we can do perimetry and all, so that then probably we might change our approach also. We might go more aggressive in these cases. But till then, as long as we are comparing visual acuity, I think we are happy getting our fovea rid of blood as early as possible.
One thing I wanted to ask, you were trying, in the first case you were trying to drain it under air.
Yeah.
So would have that been easier if you would have changed to air fluid and then tried to drain, because it was not coming out? Because I haven't tried draining it under the air subretinal fluid, or maybe
Air has
suprachoroidal.
the advantage of raising the pressure. So I think when we drain suprachoroidal hemorrhage,
Yes.
we would resort to PFO if it is not draining well under fluid. So we try to put PFO to compress the blood and shift it towards our sclerotomies wherever we are trying to drain it. So if I would have, I just gave it a try, because I was not sure whether I would be able to drain subretinal blood transclerally. Right. So that's why I think I did it under air, because I decided that I had to do it now. Sitting.
mirroring
ILM peel before injection is when you want to try the technique of not actually going into the subretinal space. That is a study that has shown that if you locally peel the ILM, the resistance of injection is reduced, and if you just put the tip on the retinal space and inject, the jet can go. It's another modification of the technique. I mean,
It's basically
it
the
doesn't
pressure you
actually help,
inject to
because anyway you still need the cannula. We are just not entering the subretinal space. On keeping it on the retina, if you inject that jet fluid from that small cannula, causes enough force that drug goes subretinally. Otherwise, there's no need to peel ILM routinely in case.
Scenarios. One is if you are dealing with RAM, having combination of sub-ILM and submacular hemorrhage, then also we peel the ILM. And sometimes what happens is you have only one 41 gauge needle and it doesn't work. So you should keep long 26 gauge needle also in your armamentarium, because you are stuck. You have TPA, but and those cases you peel ILM, so that even 26 gauge retinotomy will also heal spontaneously without any laser if you peel ILM.
Sir, and I was reading a report there, they do a partial air exchange at the end of the surgery. Do you also routinely perform it?
Complete FG is part of routine all vitrectomies. That's what we do. I mean,
Okay.
So especially in these cases, it's better to do complete FG and give 1 day. If you're injecting subretinal air, probably initial prone position for 6 hours and then onward sitting position is what it is. Now introduce Dr. Subhendu Boral, Senior Vitreoretic Consultant from Disha Eye Hospitals, Calcutta. He'll be talking about the radical maximum surgery, the primary goal, technique, and how to improvise the outcomes.
So I will summarize what is the primary goal of doing this kind of radical surgery in massive submacular hematomas. We should know why to treat this submacular hematoma urgently, because of its barrier effect, toxic effect of the iron and hemosiderin, fibrin infiltration between the inner and outer segments of the photoreceptor, shearing of the outer segments of the photoreceptor from the contraction of the hemorrhage, and ultimately submacular fibrotic scar formation. So retinal damage, which can occur as early as within 24 hours, window of opportunity is within first 2 weeks of onset. So this is my algorithm I am just managing this submacular hematoma for last more than 12 years, and I landed up in a lot of problems, but I summarized in an algorithm form that less than 4 millimeter in size, less than 2 weeks duration, only anti-VEGF on pneumatic displacement will be enough. But if it is more than 4 weeks diameter and more than 2 weeks duration, these kind of procedures are all required. If it is confined to the macula or extending inferiorly 2 to 4 weeks duration, non-drainage procedures, whatever already discussed, is helpful. If it is extending beyond macula 4 to 8 weeks duration, drainage, or it is more than 8 weeks duration, drainage along with RP coated patch graft transplantation is necessary. So for me, non-drainage is non-radical, but drainage is radical. Even when we are going for the retinectomy or with or without RP coated patch graft transplantation, these are absolutely radical surgery. So primary goal of radical surgery to decrease the destructive effect of blood in the subretinal space. Number 2, to facilitate the visual recovery in some almost no hope situation and to decrease the further vision loss. So submacular hemorrhage, significant size, I am talking about the second category, more than 2 weeks duration, extending beyond macula 4 to 8 weeks duration. So drainage, either subretinal TPA with retinotomy along with subretinal blood removal, or subretinal TPA with temporal retinectomy along with subretinal blood removal. Like in this case, vision decreased for 1 month, vision is PLPR. I have injected subretinal TPA followed by making retinotomy, what Dr. Dipender already described it, some kind of minimalistic approach, and remove the blood as much as possible. I am choosing 2 areas of doing planned retinotomy, diagonally just opposite, making one infratemporal, and another is supratemporal, so that to maximize the blood from the whole fundus. Now the macular area and superior area is not free of blood, so I made another site of retinotomy, and most of the blood is already lysed because you have to give some time for the clot lysis. It varies from 10 minutes to 45 minutes after injecting subretinal TPA. Then settle the retina, do laser, and you can end up with either gas or oil. I have my oil is my tamponade of choice. So post-operatively patient improved, and but unfortunately some kind of ERM developed after 3 months. When I removed the oil, I was also removed this ERM. So this is another case, 6 weeks old hemorrhagic retinal detachment. PR was inaccurate. Just see the situation of the blood, and but not more than 2 months. So I injected subretinal TPA first, then 2-3 areas, then waited for some time, at least 15 to 20 minutes, then started doing retinectomy from the temporal side, and you can see the old lysed blood is coming out. They are almost all dehemoglobininized blood. Lot of subretinal clotted blood is coming out like this, and then settle the retina with the help of PFCL, and you have to treat the case like just like GRT and do under the laser, PFCL, you have to do laser all around, as well as taking care of this cornu, and with the help of this Sandler slide, direct silicone and PFCL exchange, injecting silicone on the left hand and removal of the PFCL with the right hand, and post-operatively you will see this very good result. Finally, patient vision improved to 6/36. So this is another category where this kind of situation, along with this old blood, that is more than 2 months. So sometimes patients are very poor, or they don't have any attendant to come to you. So in these areas, so where there is old blood, and you have to go for the radical surgery. So you have to make, sometimes you are planning for the retinectomy. If they going to directly go for the direct retinectomy as close to the ora serrata as possible, just to avoid post-operative hypotony, because you are keeping the exposed RP a very less area of exposed RP, so that rapid absorption of intraocular fluid will not be possible. So second stage is removal of the all subretinal blood, old blood. Sometimes they are lysed, sometimes they may not lie. So you have to remove all clotted blood very carefully, taking care of the overlying neurosensory retina, and finally the subretinal scar. That is the toughest part of removal of all subretinal blood. Then removal of the CNVM, that is another very tricky situation. Sometimes you may get this kind of fleshy CNVM. You have to be very cautious about its surrounding additions, especially with the neurosensory retina, and just remove the with the help of cutter only. You have to remove all the scar and try to cauterize, do gentle cautery to the feeder vessels to prevent postoperative recurrence of the subretinal hematoma. And now if you are planning for the RP choroid patch graft transplantation, you have to inject PFCL to keep the under the retina, so that to keep your flap away from your working side. Then choose a relatively healthy area of RP, and by manually you have to shift this RP choroid patch graft under the PFCL into the proper side of the fovea. Then graft alignment was done. Then remove PFCL slowly, not to dislodge this graft, and just inject the PFCL again to keep the retina in position. Then start doing fluid exchange or inject more PFCL just to avoid retinal fold formation, and treat the case just like GRT again, and direct silicone oil PFCL exchange. So these are few of my cases post-operatively. You can see the graft will be just slowly it will be incorporated into the underlying RP, and few cases more. Till now I have done more than 17-18 cases. So I have published my long-term clinical outcomes of submacular blood removal with RP patch graft transplantation, full thickness RP choroid patch graft transplantation in long-standing large size submacular hematoma in IGO. And this is the taking all the categories, real world outcomes and complication of different surgical outcomes for different surgical approaches for significant submacular hemorrhages. These are the real world complication. You have to, like non-radical versus radical. If you consider non-radical, means non-drainage, you have to be very cautious about the recurrent submacular hemorrhage, recurrent vitreous hemorrhage, and hyphema, as well as macular hole formation. And if you are considering the radical approaches, you have to be cautious about the recurrent corneal blood staining and epiretinal membrane formation. And if you are considering the RP choroid patch graft cases, you have to be very cautious about the hypotony as well as recurrent RD. These are the few complications, non-drainage complications like recurrent submacular hematoma, or in the right hand side recurrent macular hole formation. This is the group of drainage, that means radical surgery, chance of return membrane, chance of hyphema, corneal blood. Thank you.
Very good talk, Dr. Subhendu. There's one question that we want to ask, because these are maximum surgeries where you're doing 180-degree, 360-degree retinectomy. So, what are your thoughts? What do you plan in this case? Because they're high risk of developing PVR following this retinectomy.
No,
Any protocol of Ozurdex or methotrexate that you give?
No. I am injecting subsilicon oil triamcinolone acetonide at the end of surgery, just over the BRRP choroid complex, so that it will act and to control the inflammation. And just before, after injecting silicon oil up to the margin of the retinectomy, I am injecting triamcinolone crystals over the BRRP choroid complex, and then inject silicon oil again, so that the triamcinolone particles will be sandwiched between the BRRP choroid complex and silicon oil. They stay for a longer time, especially in the initial period, but chance of PVR formation is very high.
You mean to say inject after silicon oil?
Silicon oil injection till the retinectomy eye with the silicon oil, go through the silicon oil and touch the BRRP choroid complex, start injecting in few drops, so that clear particles, that works nicely. And believe me, lot of reply is coming out from even from Shankar Nethalaya. Dr. Chetan Rao told me it is an excellent technique, especially during 360p RR cases, as well as in other situation where you can immediately stop you can minimize the formation of PVR.
Yeah.
It is not like
Thank you. Thanks, Dr. Shubhendu. And we are out of time now, so we'll be concluding it. Thank you everyone for being part of this course. I thank all my co-instructors. And maybe we can have a one click before we disappear. Thank you all. See you next year.